Thank you for your patience, ladies and gentlemen, and welcome to this first inaugural alumni event. I want to describe how I got interested in this idea on conjoint coping. I'd love to be able to say it was through reading the literature, but it was actually in the Wesley Breast Clinic in late 1985. I was holding my then 6-week-old younger son, Chris, in my arms as my wife, Barbara, and I better get this story right since she's in the audience, was going back and forth having tests for a lump in her breast, which we feared might be breast cancer. One of the things that's difficult in that situation, well, there are many things, but one thing that was particularly difficult for me was a little bit of knowledge, but not a lot. I knew that if you developed breast cancer when you were pregnant, often it spread quite aggressively. I also knew that if you were breastfeeding at the time, that the extra hormones, female hormones circulating, made the prognosis much worse. So I was pretty anxious, and so was Barb at that point. And one of the things that I noticed through that day as she went back and forth, and we were there a very long time, was that nobody spoke to me for the whole day. And I had one of the worst days I've had for a long time. Now, as it turned out, it was a non-malignant tumour. But just a couple of years later, Barb's mum was diagnosed with colon cancer, and that didn't have such a good outcome. And what I realised through those experiences was when you have a major life trauma, a life-threatening event like cancer, you don't get through it on your own, or at least you don't if you're fortunate enough to have people around you. And that got me interested in the idea of how do we effectively help each other through the difficult times in life. So I want to just cover these things. What is this notion of conjoint coping or collective coping? Can we assess it? Can we promote it? For those people who did undergraduate psychology here, it's almost inevitable. Whenever you did it, you would have heard of someone called Hans Selye. And he developed this classic notion of the fight or flight response. The idea that when something aversive happens, your body switches on physiologically and psychologically to help you either run away or beat up the threat, which doesn't work terribly well with work stress or other chronic psychological stresses. And that's how we've come up with this idea that our adaptation system for stress is sometimes mal-suited to current chronic psychological stresses. More recently, Shelley Taylor has talked about the idea of the tend and befriend idea. The essential idea of this is that if you look at us as mammals, we're actually not all that good at survival in some ways individually. We don't run all that fast compared to most predators. We don't have big teeth. We don't have big claws. We're very heavily reliant, and have been for most of our evolutionary history, on other people around us to survive. And to facilitate that, we've developed a whole range of things which enable us to communicate back and forth and to collaborate more effectively. Our ability to recognise facial affect, to be able to talk together. And so one of the ideas that Shelley Taylor talks about in particular is that this is a very important but often neglected aspect of how humans cope with stress, about how we turn to each other and develop effective ways of managing. And I've been interested in that for quite a time. Like many psychologists in the School of Psychology here at UQ, I'm much more interested in what people actually do than what they think they do. So I tend to go and observe things and try and look at them directly. So when I'm trying to assess conjoint coping, we've developed a couple of different strategies for doing that. One is we ask people to talk together and we video what they're doing. And one of the things we look at is their capacity to support each other in difficult situations. Just to give one example, we did some work with recently married couples a few years back now, where we sent them a tape recorder and we asked them to talk together about something that was stressing them in their lives but was not part of their relationship. And then we looked at the way that they talked to each other and rated their communication. The other thing that we've done is interview couples together about how they're coping with difficult situations, and then look at the way that they construct their coping in the answers that they give. Let me give you an example of the sort of research that a doctoral student of mine just recently finished. We looked at couples who'd been married on average for 5 to 6 weeks. We recruited them through the Queensland Register of Births, Deaths and Marriages, and we got them to do that social support task. And we looked at people who were effective in communicating support to their partner and those who were less effective, low and high in support. And what we showed is 6 weeks after marriage, you could see significant differences in the levels of relationship satisfaction that people felt if they received higher levels of support than if they didn't. So this capacity to be able to support each other seems to be related to how satisfied people are in their satisfaction from very early on in the relationship. But of course people go on and they do all sorts of things, and one of the things that we're interested in was some of the major transitions that people go through. So we looked at the idea of people forming step families. About 1 in 3 children in Australia is raised by a step family. We asked couples to come into the lab and we interviewed them about their relationship history, when they first meet each other's children and how it was going. And we looked at people early on in the relationship. And then we followed them. They'd been together for, on average, for 2.5 years at the first time, and then we looked at them 5 years later. And one of the things we coded from the videos of the interviews was the extent to which they reported feeling a bond as a family within that step-family arrangement. What the quality of the step-parent-child relationship was like, the extent to which the 2 adult partners agreed about the way they should approach parenting, and the extent to which as a step-family they had rituals where they engaged together in pleasurable activities. And we got an overall score of step-family bond. And what this research shows is the relationship satisfaction of the partners when we first interviewed them and 2.5 years later, about 5 years after they'd first got together. You can see that for those who were high in this ability to sort of form a meaningful bond together and to talk to each other meaningfully about their history, they started with much higher satisfaction and they sustained that high relationship satisfaction, whereas those who had lower sense of bond or positive coping with the world together tended to deteriorate in their relationship satisfaction over the next few years. So what that research was suggesting to us was we could assess different ways in which people were jointly coping, and that predicted the trajectory of their relationship over time. Then we were curious, can we teach people these sorts of skills? We developed something called the Couple Care for Parents program. This was a joint coping for people who are having their first child together, trying to see could we help them to be more effective in supporting each other. We chose the transition to parenthood because we know that a substantial proportion of new parent couples, over 40%, show a reliable decrease in relationship satisfaction from before the birth to a year or so after the birth. So we wondered if we helped people to cope together more effectively, would that enhance their ability to manage the transition to parenthood? We thought that not everybody might need this, so we looked at who might be the couples who would be most at risk for deteriorating relationship satisfaction as they became new parents. And we developed these indicators as an index of risk. So the more of these points that you had, the higher risk you were seen to be in having a deteriorating relationship as you became new parents. We randomly assigned 250 couples who were recruited when the woman was between 6 and 7 months pregnant to standard antenatal and postnatal care, which we call Becoming a Parent, and the Couple Care for Parents program, which was something that people did predominantly at home. It had 6 units. It looked at expectations about being a parent together. It promoted positive communication and conjoint couple coping. We were interested, did the Couple Care program help, and did the risk index moderate the benefit of the intervention? Everybody has their favourite slide. This is my current favourite database slide. It shows the changes in relationship satisfaction from 3 months before the birth, when the woman's about 6 months pregnant, to 3 years after the birth. The red lines there indicate the high-risk couples, those who had a lot of those indicators, and the yellow lines, the low-risk couples. The dotted lines are those in our control group. So you can see that the high-risk control group shows a very large decline in relationship satisfaction across that 3-year period. And the low-risk couples in the control group show very little. This is our Couple Care for Parents program. And this is the low-risk couple care program. What you can see essentially is that for the high-risk couples, the Couple Care for Parents program prevented the decline in relationship satisfaction across that 3-year period. Whereas for the low-risk couples, they really didn't need the intervention. So we thought, okay, For transition to parenthood, it looks like promoting conjoint coping does make a difference, at least for women. We also showed they had better parenting outcomes and that when you observe them playing with their kids, they were more sensitive and responsive when they were parenting, the high-risk couples, if they'd been through the Couple Care for Parents program. Then we thought, let's take a more extreme stressor. And you won't be surprised, given the introduction that I gave, that we focused on women who were recently diagnosed with breast or gynecological cancer. And we went to those women, went with those women when they first went to their oncologists and were told that they were diagnosed with cancer. And what we did was we offered them the opportunity to participate in a psychological support program designed for them and their partners. We randomly assigned 110 couples, so all the women had to be in a relationship, who had either breast or gynecological cancer, to standard medical care, to a cognitive behavioural coping strategy for the woman, just targeted on her, and to a couple coping program. And the question we posed was, could first of all we improve couple coping in response to diagnosis of cancer, and did that help the woman in particular deal with the understandable stresses of dealing with a life-threatening illness? We videotaped, and we were very fortunate to get this data, videotaped the couples talking to each other a few days after the woman was diagnosed and before she went into surgery, and then about 6 months later after she'd been through all the medical treatments and she'd also received our psychological intervention, or she and her partner had received the intervention. And this shows for the 3 conditions coded from those videos by undergraduate students who sit in semi-darkened rooms, which is something I do to undergraduate students. They watch videos of couples talking to each other, and it shows the rate of couple coping statements. They're things like, we did this to support each other, how we got through this together was. And what we showed was there was a substantial increase in the couple coping discussion when they received the couple-based intervention, but no change for the other 2 conditions. So we can teach it and we can see it in the way that people talk together. This shows the degree of stress or strain that the women reported in the 3 conditions from the initial diagnosis, after they've been through the medical treatments and our psychological intervention, and 6 and 12-month follow-up. What you see here is that, understandably, people show high levels of distress when they're first diagnosed. They're not sleeping well, they're wondering if they're going to live, are they going to be a burden on their family, will my partner still love me if I don't have a left breast anymore? It's a very difficult time for them and for their partners. Most of these women had early stage cancers, which means the prognosis was pretty good, so their distress goes down because most of them have been treated successfully. With the individual medical and psychological treatments, that rate of benefit then plateaus off, and a substantial proportion, about 15 to 20% of the women, have long-term problems with depression and post-traumatic stress disorder in particular over the next year or so. Whereas the couple coping intervention showed substantial and continuing improvements through to the follow-up. So, conjoint coping, we can assess it reliably. It does predict important outcomes. It can be taught. And where I'm up to now is we're most of the way through a trial of a couple-based intervention for men who've been recently diagnosed with prostate cancer. And we're trying to pose the question, does a couple coping intervention also assist men when they're dealing with that very common cancer? And the study after that we plan to do is one on couples in which one of the partners has colon cancer, which is ideal for looking at gender differences. It's a common cancer, it affects men and women in the same way, and we'll be able to look at whether or not there are differences in how men seek out and women seek out support from their partners. Thank you very much for your attention and coming along today. It's now my pleasure to hand the baton over to my colleague, Professor Jason Mattingly.